Um, After the birth, whenever first things first, like whenever we're handed the baby and it's time to begin the assessment, sometimes it's out of sorter because it'll be done on the skin of the mother, so they can have that skin to skin contact and all that. But we're giving the baby immediately when we want to start drying it off, getting all those wet linens off, so we can get an accurate weight and so that get some of that liquid off it, especially because it's not always, So we'll take the baby, put it on the scale. We're gonna weigh it for pounds and ounces so that we can tell the parents. But then we use kilograms, so we also need the kilograms. Sometimes the scales, you can use a measuring tape, sometimes the scales will have them, so you want to get that head to toe measurement in inches, but we use centimeters, so inches and centimeters. So yep, and then with that, if you were using measuring tape, you already got it and all that, you can go ahead and do the circumference of the baby's head, chest, and abdomen. And then, yeah, that's pretty much it for that stuff. So then you would like to get your stethoscope. And there's a couple things we want to listen to. First, we're going to get the heart rate, get that initial heart rate. She'll be high, like 130, 160 range. And then, or 110 to 160. Respirations, 30 to 60. And then we're going to listen to the lung sounds, all of the lung sounds. And then on the back of the baby as well, the lung sounds. And then while we're already using a stethoscope, jump ahead to abdomen and cardiac so we can get make sure that baby's got some bowel movements going already. We want to get those going. And then the 5 cardiac spots, so aortic, pulmonic, cypulmonic, the apex, the tricuspid, and the mitral. So that will be all for auscultation, I'm pretty sure. Yeah. And then we're gonna do a temperature, which I was in nursery today, and they hate it. They hate the temperature. So you put it, the auxiliary temperature, get that, and they absolutely hate it. And so then while we're doing all these assessments and stuff, we're reading the baby's face and body language for pain. Based off of like different hospitals use different scales, but you're basically doing the same thing. Trying to get a pain rating for the baby. So while you're doing all that, you're also doing a skin assessment. So in the hospital today, they washed the babies before they did this part, but it just depends on where you work, I guess. But so skin should be accurate to that of its genetics of its parents. So white parents, white baby, yeah, that's self-explanatory. And then they're really red, and then like they get closer to their skin color like as time goes by. It's pretty fast actually. And we're checking that skin turgor, making sure that we got that. The preterm babies will be like a thinner, stickier skin, while the term babies be like smooth, soft, good elastic rebound on the skin. And then the lanugo, the hair, that hasn't quite started to fall off yet from inside. Get a rating on that. My baby for my care plan today had 2+. 2+. He had a lot of hair. Or I'm not sure if that's a lot, but he had a lot, so I don't know what would be higher. I guess maybe 3, but and then the Vernex, like that, like cheesy type substance that they said that Professor Harold talked about in the video. She said to leave it. 2 of the babies that were born, one was a C-section. I'm not sure if that's why they like completely cleaned its skin, like even the cracks and stuff. They were getting all of it off. Not sure if that was like a special circumstance. And then the other one, they left a majority of it. So maybe that's just changes between the nurses. A lot of it seems to change between the nurses, what they do. And then rashes also. The baby had jaundice. Not the baby that they were washing, but I saw the Mongolian spots on a baby. There was a baby with those, so I got to see what that looks like. So yeah, checking for rashes. And then also we're gonna do reflexes. So the Moro reflex, it's like dropping it. You don't have to do that because you can just go like this and they do it, but you want to make sure that in that beginning stages of life they have that reflex. And You want to make sure it's symmetric, so both sides are working, so it's both together, not just one. Like for the eyes, the blinking reflex pin light, the pupils are round and reactive to light. Yeah, so those, and then the rooting. So like whenever you feel on the cheek, they should turn, and like the description online is like they turn towards it, but like in real life it's like they try and eat your finger, because which takes us to the next reflex, the sucking reflex. They will suck on anything. So they're trying to get your finger, and then for that one, that's good to have the sucking reflex. And then while you're doing the assessment in the mouth and area, you're looking for like a cleft lip or cleft palate. Because, yeah, obviously. So, tonic reflex. Oh yeah, when you turn the head this way, you want the arm to react, both sides turning, arm to react. And then trunk innervation, similar. Run a finger down one side of the back. They should turn to that side. Other side, they should turn to that side. And also while you have them prone, they should like have that crawling reflex. I don't remember what that one was called. Prone something. But also while you have them prone, you can go ahead and look to see if their butt is symmetrical, because it's a good sign to see if they checking for the dislocated hip, because we do not want that. So then you transition from the reflexes into the head to toe assessment. So you're assessing the baby's head. You're just looking at its general shape. All of the babies had a different shaped head today. I mean, it's pretty similar, but different for each one. So you're feeling like the front and back fontanelli. Want it to be flat, no depression, no rising. And then edema. Like you feel in the molding, like some of the babies had like a cone head, because their head hadn't quite filled into its regular shape, and so like that cone head, I'm not sure if that's the same as edema, like the caput subsiccandium or whatever. I don't think it is. I think that would be more like if it was in a different area. I think the cone head is just the molding, like it's shifting. And then if they had a blood blister, it'd be cephalohematoma, because there's blood involved. So that is all for head. The face, when you're just doing a general overview of the face, looking for mainly symmetricality. So the eyes, so I'll start with the eyes. You want the eyes to be symmetrical and in line with the outer canthus of the ear, or outer canthus of the eye in line with the ear. One of those, yeah. And then symmetrical color in the eyes too, on both sides. And then you're looking at the sclera, cornea, doing the red light reflex to check for congenital cataracts. And conjunctiva should be pink. Some of the babies, obviously this is like when they're first born, but like some of the babies, I didn't even see their eyes today, because they have that erythromycin on for the antibiotics, so their eyes are like almost glued shut. So what am I missing on the eyes here? I already talked about the perla and blink reflex. So. Oh, the lacrimal glands and the lashes. Those, and then the color. So then the ears. Into the ears, the outer canthus in line with the ears. That's a warning sign for a potential Down syndrome sign. It's not diagnostic. It's just assuming you'd look out, but. Looking for ready recoil, that the ears recoil, and you can feel the cartilage. And while they're at the hospital, they'll do a hearing test, but you're also looking with the eyes and the ears for like tracking. When they hear their mother's voice, they turn towards them, like they're aware with their eyes and ears. But they'll have an actual hearing test while they're there. You're gonna check for the actual presence of an ear canal, because that's also a sign of a heart defect. Ears, canal, yeah, so, and then the mouth, I already talked about that, the cleft, but you also want to make sure that they have a freely moving tongue, so that they'll be able to breastfeed. That's important, so that they can swallow. The nose will be smushed down because they've been inside of their mother, but you want to make sure that both nares are patent, they're breathing through both nostrils. Okay. Okay, is there anything on the face? So they'll have a short neck, but they have a freely moving neck, and make sure it's freely moving. They have strong necks in the video. The Sir Earl showed us that. You want to check for extra skin folds because that would be a sign of a warning sign of Down syndrome too. So yeah, and so then the clavicle, I actually had a baby today with a broken clavicle on the left side. But you're feeling for bumps or anything, any signs of a fracture, anything like that? Pretty common, the nursery nurses said, in births. So I already covered the chest with the auscultation pretty much, but you want to note in your documentation if they're easily breathing, like note any retraction or anything like that, because that's not good, like the grunting or anything like that, any labored breathing. Term babies will have elevated breasts and nipples, so we document that as well. And then the abdomen, already listened to the sounds, checking the umbilical cord for any signs of infection. That's an important one. Listening to the femoral artery, or no, palpating the femoral artery, and then feeling for inguinal hernias. So then the extremities, make sure they have 5 fingers, 5 fingers, 5 toes, 5 toes. The extremities should be like flexed and moving. They should be moving their arms and legs symmetrically. Their arms and legs should be symmetrical. Oh, and then the spine, when you have them prone, this is also part of that, the making sure that buttocks is aligned. The spine is like a C-shaped inwards. So you're making sure that you feel the spine, make sure they don't have any obvious like things that you can feel defects. And then with the hips, the Ortolani's maneuver, pushing it out and down, you can feel that click if they have a dislocated hip. So the spine, yep. And then, the genitals. So for the girls, a more term baby will have more skin, more labia mons. Clitoris will be less protruding because they have more developed skin. It's okay for babies who are born to have some vaginal bleeding. That's normal. And then for boys, you're making sure that urethra is at the top of the penis, not on the front side. And then checking for the rugae on the scrotum, which is also more common in term babies as the skin has time to, skin folds come with time. And then, feeling the testes to note if the testes have descended or not. And then the rectal, some places still do rectal temperature, so if you do that, you'll already know that the anus is patent. If you don't, you'll know when the first bowel movement happens, or if it doesn't. That first bowel movement will be black and tarry and sticky. And then depending on if they use formula or if they're breastfeeding babies will have more watery stool, whereas the formula forms a more formed stool. We want them urinating and going to the bathroom, passing stool, for each day they're born. So first day 1 time, second day 2 times, third day 3 times, fourth day 4 times, and so on. And then after 7 days, 4 to 6 times a day. But obviously, the more the better, especially in babies that are having struggles with their liver, getting that bilirubin out. The more they eliminate, the more bilirubin they're getting out. So with jaundice, I got to see 2 babies today who had jaundice. One of them, both got discharged because one had their levels, it was 12 at 24 hours, which is pretty bad. And then it was down to 2, which was 2 at 72, so 48 hours later. It was good, and they got discharged. And then one was at 11, and then at 48 it was at 10, and then 72 is still at 10, and then on the whatever another day is, It was still at like 9, but they sent the baby home because levels weren't really moving, but he didn't look bad. Like all his vitals were good. It's time for him to go home. So jaundice is when that extra blood cells are getting broken down. The liver is immature and it can't keep up, so the bilirubin builds up. So getting them going to the bathroom helps. Eating more, feeding more. Encourage the mothers to feed them at that 3-hour mark. It's good. The UV light to break down if they need aid, like those babies did. So I believe it's physiologic jaundice is okay when it's just in certain spots. Pathologic is bad when the whole body is yellow. So you can do that press test to see that color change. So let me see, make sure I got everything. Yeah, I think it's good. Oh yeah, similar to the postpartum assessment, noticing the different types of cries is good, especially for the mothers. It's easy for the people in the nursery to tell because they like today my nurse had 7 babies, so she hears babies cry all the time. She hears it, but it's important for us to educate the mothers, and they have to figure it out as they go too. So